Communication is crucial to creating the best end-of-life experience. Today we're talking about what to say, how to say it, and when to say it. You're connected with the Heart of Hospice.
I'm Helen Bauer, here with Jerry Finter. Whether you're a family caregiver or an end-of-life professional, we're here to enhance your hospice experience by connecting you with information you can use about end-of-life care.
This episode is sponsored by BeyondWordsCo.com. Beyond Words ensures no one feels alone through life's hardest times. Their care packages support those going through grief, loss, or difficult life transitions. You can also send a care package for birthdays, retirements, promotions, well wishes to encourage, say thank you, or just show appreciation. Order your custom care package at BeyondWordsCo.com. We are both communicators. We talk a lot.
Yes.
And we talk about a lot.
Yes. I'm trying to figure out if this is getting ready to be insulting.
No. Communication's a good thing. Communication is the lifeblood of good hospice and palliative care.
Really, probably communication is the most important tool you can have in your arsenal of tools when you're in any line of healthcare, but never more so than when you're in end-of-life care working with seriously ill patients and their families. So that's what we are focusing on today. And I want you to raise your right hand.
Okay.
Raise your right hand.
Yes.
I state your name.
I, Jerry Finter.
Promise not to get worked up.
I'm sorry. I can't promise that. Seriously, these issues that we're going to talk about are ones that we have faced ourselves. Some of these are mistakes that we've made.
Right.
And I'm saying we.
Right.
Man,
I claim that. I will claim it.
Yeah, I do too.
And some of it is things that we have read in documentation or situations that we've seen arise among coworkers, colleagues, connections, people we know that work in healthcare. So it's like the motto that I want to claim for us, a slogan that we didn't write. We know a few things because we've seen a few things.
This is true.
We are not farmers. However,
yes,
we have seen a few things.
We have, and we have a lot to share. And there's probably some things that we don't include in this particular episode about communication that we should have. And if we didn't include maybe your particular idea or issue, well, write us. Just send us an email.
Only the nice things, please.
Right.
Okay, so everybody needs to know how to communicate. And when we say everybody, we mean everybody all the way from the core members of the interdisciplinary team, the other members of the interdisciplinary team, patients, and their families or caregivers.
Right.
So we're going to look at all of that today.
Right. In fact, we're going to break it down into those categories. We're going to talk about how patients can communicate with their team. We're going to talk about how the family members can communicate with the team or caregivers, family members, caregivers, and then how the team communicates not only with each other, but also with the patient and the family.
So we're going to start with the single most important person who is at the center, literally, of everything we do, our patients.
Right.
Our terminally ill, seriously ill patients. So here's what we want to tell you to support you in your hospice experience with your team. What do you need to communicate if you're a patient?
Yeah, this is very important. So if the patient is alert and oriented, able to communicate, and this is what you need to communicate. This is what's going to help the team be able to give you the best care.
Right. Help me, help you, help me.
Right. Something like that.
Yes. So it's really important to be open about your symptoms. We understand that it is private. It's painful to talk about some of these things. It's embarrassing. However, I will tell you, as a 30-year veteran of nursing, I have heard it all.
Right.
I'm not shocked. I might be a little surprised sometimes, but all of that is information your nurse and the rest of the team need to take care of you.
Well, what it comes down to is we don't know how to help you if you don't tell us what your needs are.
Exactly. Exactly. So you want to report changes timely. Changes in your caregiving system, changes in the way you've responded to your meds, changes in your condition, your status, how you feel, what you're thinking, any wishes that you have. Important to report those things timely, because if you've had a change, say, in your wish about your resuscitation, if you want to be a DNR, a do not resuscitate, you need to let us know that. We will help you get the paperwork written. Your social worker, your chaplain will counsel you. We'll all provide support to you. So you want to report changes like that very timely.
Right. So anytime that you have some fears or concerns about the safety of your caregiving system.
Right.
That even includes the hospice team.
Right.
If you have some concerns there, you need to talk about that, because one of the things that we simply cannot tolerate is abuse, neglect, or exploitation, or drug diversion, anything like that.
Right.
Those kinds of things we need to know about. Don't hesitate to let someone know about those kinds of things.
Right. So if you're a patient with a caregiving system that you don't trust or you have concerns about, and you want to have a private conversation with somebody on the team about those fears or concerns, if you're afraid for your own safety or how you're being taken care of, ask to have a private conversation. Tell your team member, I'm scared of this person who's taking care of me. They're taking my medications. They don't feed me. I'm neglected, etc. Let us know. And we will tell you that your hospice team member should not leave you until you are safe.
Absolutely. Okay, so in that same vein, complaints,
yes,
should also be brought to our attention. Again, we don't know what to fix if you don't let us know what's wrong.
Right. It's your right to make a complaint about the hospice team, about the care we're providing. We would ask you to do it respectfully, and remember that the people who are providing your care are still human, just like everybody else. But if you feel that the care is substandard, or it's something you didn't want, or it violates your rights, or it's just bad care, let us know. It's your right to do that. So you can complain to a team member. You can complain to an administrator or a director for the agency. If you feel like it's still not handled, or you feel like it's something much bigger, you can report to the state, and you can report to the accrediting agency for the agency if they have one.
So accrediting agencies such as Joint Commission, ACHC, CHAP. Yes.
And contact number and the names for the accrediting agency for your hospice company should have been information that is provided to you when you're admitted.
All right. So on the flip side, it's also good if you tell us about the good things. So maybe you have a great CNA who's doing a wonderful job for you. Let us know about that. Tell us the compliments that you have for your team, because it builds up the team morale when we get compliments from our patients.
Oh, yeah. It makes us feel awesome.
Yes, yes.
So we also want to hear from you if you have questions about the care. What to expect when you're expecting hospice, what to expect from the team. Each hospice team member that comes in should be explaining why they're there that day, what the role is, and here's what we're doing today. Today, I'm going to change your catheter. Today, we're going to talk about your memorial service because you told me you wanted to make some plans for that. Things like that. Also, what can you expect as your disease progresses? What's the trajectory? What's that going to look like for you? I think a lot of patients have questions about, as my cancer advances, what am I going to be able to do? What can I expect to lose? What should I look for? And I think those are good questions to ask.
They really are. And so I've even had patients who say, I'm not really concerned about dying. I'm just concerned about the process of getting there.
Right. What's that going to
look like? Am I going to be in pain? Am I going to have such shortness of breath that I feel like I'm suffocating? And so there's that concern. you need to share with us your concerns about that kind of thing, because we can help alleviate some of your concerns by explaining to you about the disease trajectory, what to expect. We have been through this with many, many, many patients, and we can help you to understand what's going to happen and explain to you how we can control those symptoms so that those fears and concerns that you have can be alleviated.
Absolutely. I think you might also have questions about what can my family expect?
Yes.
Right? Because they're the people that are going to be doing the heavy lifting for you when your care gets closer to the end of your life. Are they going to be able to handle that? How will the hospice team support my caregivers as they do this? What's that going to look like for them? I think a lot of times patients have worries and concern for their family that's having to provide their care. They're worried about the caregiving burden. And so knowing what the team's going to provide and how things will change and move, I think that's important to a lot of patients. So ask those questions. So for hospice providers, you're listening to this, we're going to get to your part of it, but you need to remember that patients need all those questions answered. It's okay for them to question what you're doing, and you should always respectfully provide an answer.
Right. And honestly, when a patient does give us questions, it makes us better providers.
Right. Absolutely. So another thing, if you're a patient, that you need to make known to us, if you have any additional needs, if you feel like there's a piece of equipment that you would benefit from that we could furnish for you, we also want you to let us know if there's something you don't want, which sounds a little counterintuitive. But if you want to refuse something because it's not part of the care that you want, it doesn't fit in with your wishes, let us know. You have the right to refuse any or all of the care that we provide. It's entirely up to you.
For instance, many times a patient says, I've only had a CNA, twice a week, but I think I'm getting to the point that I need a CNA 5 days a week. Those kind of changes can be made.
Sure.
You would just need to let us know. Also, if you have an appointment with a nurse, social worker, chaplain, and then something changes in your schedule, you need to let us know about that.
Oh, please let us know.
Yeah, that's just more of a very technical aspect of that.
It's just a courtesy.
It is just a courtesy. Let us know that you're not going to be able to make that appointment so that we don't miss you.
Right. We don't drive all the way out to your house. If you want to change in the schedule, or you're just having a bad day. I didn't sleep last night and I want to sleep, or my caregivers didn't sleep during the night because I was up and down. We would prefer to move the visit to tomorrow. Just let us know. We're more than happy to accommodate the schedule if we can. And the single most important thing is your advanced care plans. We need to know what your end of life wishes are. What do you want? What do you not want? What gives your life meaning and hope and quality? And what are the things that you no longer feel are important? Taking different meds that aren't particularly effective and just give you another pill to take. If you want to get rid of those and you want to refuse that part of it, you let us know. We want to have those conversations with you. So communicate that to us.
Okay, so those are some of the things that we want you to communicate. So that's what to communicate. Now we're going to go into when to communicate these things.
Right.
So these are just a few tips to think about. Symptom changes need to be reported quickly.
Quickly, please.
Don't wait on those things. And of course, you need to report immediately any urgent needs. And if there's no answer, call back. Keep calling us. But
rule of thumb, 20 minutes. If you don't hear back from someone in 20 minutes, that's not a regulation. It's not anything like that. But I would tell you, best practice, if you don't hear back from someone in 20 minutes, technical things fail, right? Phone lines, answering services, messages, things get missed. If nobody calls you back in 20 minutes, call again.
Right. Now, there are some things that don't need immediate attention.
Right.
And if it's in the middle of the night and, it doesn't require immediate attention, then call the next day.
Sure.
Just make that call the next day. And here's just a general rule of thumb as well. Anytime you don't know what to do, just pick up the phone and call us.
Right. We're happy to answer a question. You may not need a visit, but we're happy to answer a question.
Absolutely.
Okay, so we'll move on to the next group, our families or caregiving systems.
Okay, so what to communicate. Families, here's what we need you to communicate to help us help you. Timely reporting of any changes. So maybe your patient, your loved one, can't communicate for themselves. So we're really expecting you to be the one to make those steps to communicate with us.
Right. You're the advocate for that person.
Right. So anytime that there are changes, we want you to report them to us. You be the one to advocate for your loved one and give us the information that we need. But also when you need some help.
Sure.
Because we're not only here for the patient, you're a part of our caregiving system too.
Right.
We're here for you. So if you have feelings of overwhelm and you just sometimes don't know what to do next or where to go, or that you just don't have the energy to go on, you need to tell us these things. Right. Communicate with us.
Absolutely. There are things we can do. If you have questions or you've gotten confused about medications or when to give, how much to give, how to give it, give us a call. Those are things we can help you with over the phone, and we'll make a visit if you need one.
Also, let us know if there's any incidents that occur, such as the patient fell, or maybe a medication was given at the wrong time or too close together or something like that.
Or too much of it.
If you have some concerns regarding that, then you need to give us a call.
Sure.
Let us know.
And again, complaints. If you have a complaint about the services, any of the hospice team, any of the way we're providing your care, those are things you want to report.
And we're going to say it again. If you have compliments, please share those with us.
You know, the important thing about compliments, it may sound like we're saying here, just pump us up, give us a little love. But what it comes down to is hospice is hard work. And we have a lot of days where it's discouraging. We see things that are sad sometimes. We do. And when you pay a compliment to a staff member or give a compliment about the care that's being provided, that's the kind of stuff that gets us through those days where things are rough, when we wonder why we're doing this work. So compliment can make somebody's day. You never know.
Absolutely. Sometimes it's what keeps us going.
Yeah, absolutely. So another thing, questions about visits. And I made a list of questions. Visits, scheduling, billing, patient rights, equipment, medications, what to expect. I mean, you could make a big laundry list of that. But what to expect is important, because anytime we equip you as a family caregiver to be able to handle what's coming to you, you're more confident. You convey that confidence to your loved one. They're more comfortable. It adds to the quality of their life and your experience with end-of-life care, especially the death, okay? Because people have a lot of fear surrounding that. Each death looks a little bit different. I used to tell patients and families, every death is as individual as the life that's been lived. You may have certain symptoms that are similar, but not everybody has terminal fever. Not everybody has what they call a death rattle. It just depends a lot of times on the patient, what their status is, and what the disease is. But if you ask us, we're going to teach you and we're going to talk with you.
So our goal is to educate you and to increase your knowledge. So one of our favorite people is Barbara Carnes. And
love her.
Her phrase that we have used over and over again is knowledge reduces fear.
Absolutely.
So we feel like if we can educate you as the caregiver, as the family member, so that you have a knowledge of what to expect, especially at death, then it's going to lessen your anxiety. And the less anxiety that you have, the less that's going to be felt by the patient. And so we want you to know this is what to expect. That way you're more comfortable with what's happening in your home.
And it's okay to ask more than once.
Oh, absolutely.
Repeat your question. This is an overwhelming experience. There's a lot of information, and most people want to get it right. They want to get all of it right, all the things, which is a lot. And then you take sleep deprivation and grief and confusion and just this inexperienced person coming into this hugely intense event. And you should ask more than once. If you don't remember all the stuff we've told you, you can join the human race because this is everybody.
That's right.
Everybody.
That's right. One of the things that we don't want you to say is, oh, I wasn't expecting this to happen.
Right. We should make sure you know what to expect.
Right.
That's our job. That is our job.
Okay, so that's what to communicate with us. Now, when to communicate. So whenever there's an emergency, a crisis situation, and you're the judge of that, that should be reported immediately, day or night, doesn't matter. So every agency has an answering service that will answer the phone after hours.
Right.
So that there's never a time that you cannot communicate with someone. And if the answering service can't answer the question that you have, they're going to put you in touch with someone who can.
Right.
Because there's always an on-call person who will get in touch with you, find out what's going on, and kind of triage the situation, and then give it to the person who can help you.
Exactly. So if it's not an emergency, we would ask that you call during normal business hours. So say your mom's going to run out of meds in a couple of days, but you got enough for a couple of days. Don't call at 8:30 at night to say, my mom's going to need a refill in 2 days. Call the next morning and identify, this is what we're going to need in a couple of days.
Yes.
Right?
Yes.
That's not an emergency.
Right. And it's more likely to be taken care of if you call during normal business hours for things like that.
Right. It's a whole lot easier for us to handle that.
Yes.
We're going to have to wait until business hours for something like that anyway, so it's better if you just call the next day.
The sponsor for this episode is BeyondWordsCo.com. There are times when sending a card or ordering a plant for someone who's experienced a loss just doesn't seem like enough or doesn't seem appropriate. When you want to do more, Beyond Words can help. Their mission is to ensure no one feels alone through life's hardest times. Beyond Words provides care packages that offer comfort when life gets hard. The products in their care packages are hand-picked so that your gift provides the recipient with moments of rest, calm, and peace. You can select a pre-designed gift package or create a custom care package. A customized care package allows you to select products that are personal to the person you're sending it to. Most of the products from Beyond Words are handcrafted in the U.S., responsibly sourced, and organic. To order a care package for your loved one, visit the Beyond Words website at beyondwordsco.com. That's beyondwordsco.com.
All right.
So we've talked to patients, we've talked to families and caregivers. So now we're going to talk to, well, the providers.
And you know who you are.
The interdisciplinary team members.
Yes. So, I mean, how much can we emphasize this? But we will tell you, communication enables a highly functioning team.
Definitely. And good communication will influence the quality of care that we as a team provide for the patient and the caregiver.
Absolutely. I don't care what country you're in, what state you're in, what discipline you are, how you communicate to the patients and the families and to your coworkers on your team makes a difference in the care that you provide.
Right. So first of all, when you come to IDT, we're talking about the interdisciplinary team meeting. And so every agency has a team meeting at least every 15 days. Usually it's about every 2 weeks, every 14 days. Yeah. There should be no surprises when you meet together. There are some things that you should have already communicated with everybody. Right.
If you're sitting in IDT and one of the disciplines says to the nurse, well, did you hear about her screaming out in pain the other day? And the nurse says, no, I didn't. This staff member says, well, yeah, when I went there, she was screaming out in pain. That was the end of last week. Oh, no.
That should never happen.
That should never happen. Not like that. Or did you know, the nurse announcing, did you know that she signed the do not resuscitate?
And the social worker says, no,
I didn't know that. No.
Yeah, that should not happen.
Yeah, there's some real-time communication about certain things needs to happen, okay? Mm-hmm. So no surprises in IDT. You might surprise the doctor a little bit. That's okay. He functions a little bit differently inside the team, but no surprises among the core team members.
Right. So let's talk about how we as a team communicate with the patients and the families, because this is a big part of what's known as the CAHPS surveys.
CAHPS surveys.
Right.
So those are, they're experience of care surveys. It's satisfaction surveys is what it is. When a patient is discharged off service, there is a satisfaction survey that is sent out. If you're a very small agency, you do it in-house and you send it yourself. If it's a larger agency, it gets sent out electronically by a company that you hire to do that for you. On the satisfaction survey that's sent out by a vendor, there is a huge emphasis on communication. How do you communicate with the patient and family? How do you communicate with each other? How do you communicate with facility staff? So it's a big focus for a team.
Yeah, it really is. And so one of those things has to do with scheduling with the patient, making sure that the patient and the family know when you're coming, and if you're going to be late for the appointment that's been established, those kind of things need to be communicated with the patient and the family.
There is a question specific to this on the CAHPS survey that says, did they let you know when they would be there? And you can say, well, they're not going anywhere. That patient is too ill and can't get out of the house. That doesn't matter. You want to respect the routine and the time schedule that they have inside their household.
Sure.
So communicate. All right. A change in the provider or the clinician that's going to be coming out there. I'm going to be on vacation next week. Kathy is going to come out and make your visits for you.
They need to know that.
They do.
They also need to know what's not covered and what's not provided. So there's actually been a change in this just this past year, I believe it is.
In October.
Right. If the family requests it, the agency has to reveal all the things that they will provide and the things that they won't provide.
Right. It's called the addendum. It's got a long name, but in hospice, we just call it the addendum. And we have to put it in writing if they request it. And there's some time deadlines on how we have to manage that. So patients and families should know any unexpected costs they might have and what the agency is not going to pay for.
So let's say that a patient is in a facility. They don't live with the family, but there's a change in the patient's condition. Then we, as the team, need to be sure that we are communicating with that family and let them know anytime there's a change in condition. As a matter of fact,
oh no, I can feel it coming.
We should communicate with them after every visit and give them a status update.
I like the way you point your finger with every word on that for emphasis. It's too bad that you can't see that on a podcast.
This is true. You shouldn't tell them I do that. I wave my hands around all the time when I'm talking.
I think they can hear it. No, it's just a sore point because we have a tendency, we go in, we tend to business, we coordinate with facility staff, but then we've made a visit and we don't communicate with that family.
And the family is our unit of care just as much as the patient is.
Absolutely.
And so even though the patient's in a facility does not mean that we are no longer responsible or not responsible for the communication with the family. We should make sure that that family knows what the patient's status is, that we went to see them and how they're doing. And if there's any changes that have taken place, we should always communicate that with them every visit. And that means every discipline as well. I'm not talking about just the nurses. I'm talking about the social worker, the chaplain. They need to communicate with that family and let them know how the patient is doing.
Absolutely. And especially in this day and age, there's a lot of restriction on how many visitors and how often a patient can have a visitor inside facilities. You may be that liaison. You may be the only person who is able to get in as a team member to see a patient who's a resident in an assisted living or a long-term care facility. The family may not have seen that person in quite a while. It's your responsibility to phone back and let them know.
Okay, so not only do we need to communicate with patients and families, we also need to communicate with facility staff. So we have a lot of patients who are living in a facility.
Right.
And they are cared for by that facility staff as well as the hospice team. And we need to have a continuity of care that's taking place, a coordination of care that's taking place with the facility staff. We need to communicate with them. And so that means care coordination, and that requires communication.
Right. And that's hard. They're busy. You're busy. One of the things that's required by regulation is delineation of duties. When you have a hospice agency that's going to have a patient inside a facility, you want to delineate who's responsible for what. This is your job. This is my job. Here's what you can expect me to do. Here's what I'm going to look for from you. Right? Super important. It's also important because we are required to have what we call professional management of a patient inside a facility, which means we're supposed to case manage the patient's care, which means we eliminate unwanted lab work, unwanted trips to the ER, x-rays that aren't supposed to be done. We stay informed. They stay informed. And then from there, we communicate to that family. And that's just all of professional management. That's how you manage the care of a hospice patient.
Okay, we mentioned earlier about not having any surprises in IDT.
Mm-hmm. So for the nurse, the things that we would look for the other disciplines to call us about, if there were any symptom issues, if there was an event, patient had a fall that was communicated to you, you want to let the nurse know. If there's anything hinky about their medications, either the patient's non-compliant or seems confused about how to take it or has taken it incorrectly, or if there's suspected drug diversion, which means someone else is taking those medications that were intended for that patient. In this day and age with the narcotics that we use for pain management, that's a concern. So those are calls that would come to the nurse. If you notice a new wound, bruising, any type of injury, that's also something you want to let the nurse know about.
Okay. So then there are some psychosocial issues that should be reported. Caregiver overwhelm. There are many times when a social worker, nurse, social worker, chaplain sits down with the caregiver and they will say, I'm just so tired.
I can't do this anymore.
Yeah, I've been up and awake. I've gotten like 2 hours sleep in the past 48 hours. They're just overwhelmed.
You might even hear things like, how long do you think it's going to take them to die? How long do you think this will last?
Yeah, I'm not sure how much longer I can go on.
Exactly.
And this is not unusual. So then financial issues as well need to be reported. Food depletion. I'll have to admit, have been a few times when I've been in someone's home and found out that they had no food in the house or very little food in the home. And that should require, all of those things that we just mentioned, should require a call to the social worker.
Exactly. So how about the chaplains?
Okay, so some spiritual issues. When a patient or caregiver expresses some feelings of guilt or hopelessness, maybe signs and symptoms of depression, or they say, I think it's time for me to begin making some funeral arrangements. Those kind of things should be reported to the chaplain, as well as anger issues or a need to reconcile some estranged relationships. Those are things the chaplain should be informed about. Exactly.
Okay, so let's talk about the things that need immediate reporting.
Right. Okay. Earlier we talked about how, there should be no surprises in IDT. These are the things that should be reported immediately.
So in other words, they shouldn't be reported in IDT 5 days from now.
And you're right. Exactly.
And of course, the first one is a patient death.
Yeah. And we bring this up and everybody says, well, duh. However, there have been occasions when a patient has died and a team member shows up at the patient's home thinking the patient's still alive.
Right. So if you are the nurse, and I'm charging the nurses with this one because we typically are the ones that go out to a death event, we pronounce the patient, get them squared away with the funeral home or, however the body is going to be handled. We are responsible for notifying the team. And a lot of time a message will go out, a secure text or an email that goes out to physician, the office, social worker, and the chaplain. And then we leave those aides hanging out.
Oh, the CNAs.
Yes. So the aide will go to the home the next day to provide personal care for the patient, only to be told that the patient had died during the night. Embarrassing.
Embarrassing, and probably the CNA has a feeling of being disenfranchised and just not included in
not part of the team.
Yeah.
Right. It also is not a good reflection on the care and the communication that the team is providing. If you can't communicate such an important thing, such a humongous event in the life of a caregiver, then, that's the kind of impression that you're going to leave with the family. That's not a good idea, not a good reflection on you.
Okay, so falls or injuries need to be reported quickly.
Right. Symptom crisis. So when we talk about symptom crisis, you're talking about things like pain, shortness of breath, vomiting, diarrhea, seizures, agitation, things like that.
Okay. Suspected abuse or neglect.
And that's immediate for so many different reasons.
Oh, yes, because simply put, that person, that patient might be in danger.
Exactly. And it's our responsibility to make sure that they are in a safe environment, being taken care of by safe caregivers, if that's the good description of it. There are certain states that require very, very fast turnaround on reporting of abuse, neglect, and exploitation. The state in which we practice, Texas, is one of those. You have 24 hours to report to the state if you suspect abuse, neglect, or exploitation of one of your patients. So that report automatically goes immediately, I would say, to the nurse, the case manager, or to your administrator or director.
Yes.
That's an important thing.
So if the patient or caregiver or anyone in the family expresses some suicidal thoughts, that should be reported immediately.
Right. And that's probably one that should be tossed to the social worker.
Yes.
Or the nurse. Well, everybody's got to know that.
Everybody needs to be informed about that, yes.
An unsafe environment, a house with no utilities. We live in the South. It's very hot here during the summer. That can be unsafe for a patient.
Right.
A patient with no water, a patient with no electricity, things like that.
Yes. Food depletion. We've mentioned this already, but that is something that needs to be reported immediately because let's just be realistic. People can't go without food.
Exactly. And we want to support our caregivers and the patient, make sure they have the food that they need. Caregiver collapse.
We're talking about the collapse of the caregiving system.
Yes, complete shutdown. For instance, and we've seen this, where a healthy caregiver, supposedly healthy caregiver, has a stroke. Catastrophic, ends up in the hospital. You've got a patient at home in a bed. That needs to be reported immediately. That somebody becomes aware of that. We'll find emergency respite placement for that patient. Social worker will work to help that placement happen. The nurse will help to coordinate that to get the clinical needs met. And the chaplain will help support the rest of the family and the patient with spiritual needs.
And so finally, anything illegal or unethical should be reported to the administrator or director immediately.
So for you hospice team members, let's talk about talking about your patients and families to other team members. You're in the office, you're in an IDT meeting, you're providing a report during a call or a huddle, or you're phoning a report to another discipline, another nurse who's on call. How are you talking about your patients and your families? Are you respectful? Do you ensure that it's a private conversation? Because a lot of times we're on the phone, we're in the car, we're out and about. Sometimes we're in our own homes. Is it discreet? Do you use labels?
Okay, so when you say labels, give me an example of what you're talking about.
You're going to hate this.
I know.
Okay. Old coot. Creeper. I won't even go with the racist stuff. I'm not even going to use that kind of language.
We're not going to go there.
But there are labels. Obstinate. There are ways to speak about patients' behaviors without providing a label. Be descriptive. He is resistant to any change. He's refusing this particular med, procedure, part of the service, equipment. Refused a visit. Requesting something. And you can say a patient refused to have a conversation about this. But labels that imply ageism, racism. What is it? Explicit bias.
Yeah, so explicit bias is pretty clear. It's the implicit bias that we don't recognize in ourselves that often gets into our speech and our mannerisms even. So we need to minimize bias. But the more we use terms, labels for people, the more our bias is showing.
Exactly.
Yeah, so we need to minimize bias. So consider how you talk about your patients and families to other team members.
So here's an example. And I once read this in documentation in an audit that I did several years ago. And it's very indicative of mindset. The note that was written was an assessment about the faith beliefs of the family. And the description that was written was, they are very Catholic.
Oh, wow.
I'm not even sure what that meant. So you understand the difference between that and saying they are devout Catholics. And then describe this. It is important to the patient to receive communion from a Catholic priest, to receive anointing of the sick, and to have visits from his personal priest. Descriptive, not a label. There's a difference. There's a difference.
Yeah, and the first one that you found on the chart was actually probably said with a little bit of bias to it.
It sounds a little judgmental. And maybe it wasn't. Maybe it wasn't, but it certainly reads that way.
Right.
Okay, so how do you talk to your patients and families?
Okay, again, respectful. Always respectful to them. And empathic. Show your true side. You're working in hospice and palliative care. Show that empathy that needs to be there. These people are seriously ill. They're terminally ill. They need our empathy.
Compassionate. You should care about these people, care what they're going through. You want to provide everything that you can to make them comfortable, that gives them quality of life.
Right.
And avoid ageism. I get really stuck on this one. That drives me crazy. And you know why? Is because I'm middle-aged and I am experiencing that when I receive any form of healthcare. Do not call me sweetie or honey. I can barely tolerate being called ma'am, but in the South, that's respectful. But for the love of God, do not walk in and say to me, how are we doing today?
Oh, no. No, I know how that works. That's like talking to a child. So how are we today? Well, I'm doing fine. How are you?
Yeah, that's all I have to say about that. That's terrible. And avoid informal terms that you would use to talk to someone you're very close to. Honey, sweetie. They're not your children. They're not your grandparents.
Or a 3 or 4 year old.
Exactly. Yeah. Exactly. So how do you talk with them? So here are some hints for this. Listen to reflect, not respond. Don't be thinking a step ahead about what you need to say to them.
Right. And watch your body language too. I always say that that communicates without words.
Oh, absolutely.
The body language does. Eye rolling?
What?
Do not do that. I've known for it to happen.
Oh, wow. I didn't even go that far in my head. I was just thinking about sitting facing the patient.
Well, this is true too. How you sit and look at them, maybe lean forward a little bit, shows that you're engaged, you're paying attention. They are your focus. That's good. But there are a lot of ways that we express ourselves through our body language.
I hadn't even thought of eye rolling, but that's pretty good. Compassionate, sensitive replies. If a patient tells you, I'm scared of, I'm worried about, avoid saying things like, oh, you don't need to worry about that.
Yes.
You don't get to decide that for someone else. Don't use phrases like, that's all part of the process. That's normal. What in the heck process are you talking about? None of this is normal because this patient has never died before and that caregiver has never watched this loved one die before.
Yeah, it may be normal to us since we work in this particular field, but that does not mean it's normal for them.
I tell you, I remember an experience years ago where a nurse on a weekend told a family caregiver for a patient who was actively dying. That's normal. It's part of the process. And the patient died a few hours later. The family had called twice with questions and concerns. The nurse did not go out and make a visit. And then after the death, they called and made a formal complaint to the administrator of the agency. And basically what they felt was that their concerns and their fears were invalidated.
Of course.
Right. And rule of thumb, really best practice is if someone calls twice, you make a visit. Maybe it is just for questions. Maybe it is for encouragement and support and to just shore them up so they feel confident in what they're doing. Totally worth the visit.
Absolutely.
Totally worth the visit.
So we should also be respectful of their culture, their roles in the family, as well as in the caregiving system, their education. Talk to them in terms that they understand.
Right. With lay people, it's not a good idea to use a bunch of medical jargon. It's not helpful. It's just confusing. And then you've left the house and actually left them in the exact same shape that they were in.
Well, even someone who has a degree doesn't necessarily mean that they understand medical terms.
Exactly. So like, if I'm having a baby, I'm not a labor and delivery nurse. I need you to explain this stuff to me. You know, it's kind of like, would you want your gynecologist to do your brain surgery? No, completely different systems. So you want to explain, even if someone is a healthcare provider or works inside healthcare, they may still not have experience or an understanding of the dying process and how hospice works. Don't use a bunch of jargon that people aren't going to understand.
Right.
Make it relatable.
And be respectful of their wishes, too. Okay, so maybe what they desire and what their values are and their wishes aren't the same as yours. Doesn't matter. We need to be respectful that this is what they want. Maybe it's not what we would want for ourselves, but this is not for us. This is not about us. It's about the patient. We should be respectful of their wishes, even if it collides with our own wishes.
So let's talk about how to communicate. And we're talking about the mechanisms, telephone, text, video, chat, emails, etc. Let's talk about how to make those messages, that communication happen.
Sure. So there are lots of ways to communicate, and there are lots of people on the team to communicate with. But here's what we would tell you. Let there be one contact number. Patients' families only need to know one number to call.
But why is that so important? Because we've all got cell phones.
Right. Well, maybe they have 3, 4, 5 team members, but they don't need to have everybody's number. They just should have to call one number. But the reason that they should only have one number is because in that moment, when there's a crisis, they don't need to figure out who to call.
Well, and after hours, the same way, right? How to choose which number to call.
Right. There should only be one number, period. And that number should be rolled to the answering service after hours so that still they don't have to say, oh, it's after hours, I need to call a different number. No, they call one number. That number during the day gets them to the agency. That number after hours gets them to the answering service.
And I know there's caller ID. I mean, you can't do anything about that unless you intentionally block your number when you make a call, but some patients and families won't answer numbers that are like that. But if you teach your patients, and I've seen agencies that posted it on the refrigerator with a magnet, this is the number you call when you have a question, you have a concern, the patient changes, the patient dies, you have a need. This is the one number you call. And there are a lot of different reasons for that. There's a whole list of reasons why that's going to be important.
Right. And we're going to get to those here in just a minute.
Yes.
Okay.
You can tell this is very important to us.
It is very important to us because we've seen it done poorly.
Yeah. Well, and we have to say that we're not sitting in judgment on anybody. Again, we know a thing or two because we've seen a thing or two. And I would add to that because we've done a thing or two.
Yeah, we've made our mistakes.
Yes, we certainly have. So best way to communicate when you're going to make a phone call in, if you're a family member or a patient, first of all, identify who you are, what your role is, and who you're caring for. Hi, this is Helen Bauer. I'm Margaret Nash's daughter, and I'm her medical power of attorney.
That's what you need to communicate when you call. That way, the team member knows who you are, who you're with, and why you're calling.
Right. And if they can talk to you or not, because things get sketchy if they're not careful.
That's right.
So if you're a provider, if you're one of the team members, identify who you are, what your role is, who you're with, and what your purpose is in calling.
Right. I'm Jerry Fenter. I'm the chaplain with such and such hospice, and I just wanted you to know I'm calling to make an appointment to visit with you sometime this week.
Awesome. And then you can say, how are things going?
Right.
But what I find with people that call and say, for instance, hi, this is Helen Bauer. How are you today? I automatically feel like you're trying to sell me something.
Yeah. Is this a sales call?
Yes. But if I identify myself fully, not just my name, hey, this is Helen with the Heart of Hospice. I'm the podcast host, and I want to talk to you about being on our show.
Right. There you go.
Yeah. Okay. You always want to consider who the stakeholders are that need to know this piece of information.
Right. Is it the social worker that needs to know? Is it the chaplain who needs to know? If you're the chaplain, is it the nurse that needs to know about something that you've just heard about? So who needs to know? Do they all need to know? Does the whole team need to know?
And sometimes I think the answer, probably more often than not, is yes, the whole team needs to know.
Right. Right.
Because a change in the patient's status, a crisis, a symptom management issue, a lot of times that indicates decline, progression in the patient's disease diagnosis. And so really everybody needs to know that.
All right. So we said earlier that there needs to be one contact number. Now we're going to explain to you a little bit about why. So to those of you who are providers listening, don't give the patients or the families the impression that you're available to them 24/7.
Why not? Because I want to be available to my patients that I care for 24/7.
Yeah, and that's a wonderful, very altruistic thought that you have, and that's wonderful that you would want to do that. But are you available 24/7? How often would you be available 24/7?
I need to sleep.
You do need to sleep.
And sometimes I'm not on call and I have family obligations, or this is a holiday and I'm actually off today.
Right.
So I guess in reality, I am not available 24/7.
No, it's really an unhealthy boundary to let your families think that you would be available. Oh, anytime you need me, I'll be there.
Right.
Yeah, and we would like to think that that's possible, but we're not Superman.
And the other thing, it's not just unhealthy for the patients and the families. It's unhealthy for you. If you are actually maintaining a life where you are available to your patients all the time, you've got a boundary that's a problem.
Mm-hmm.
You need to look at what you're doing and craft and protect your personal life.
Right, because it puts you at risk of burnout or compassion fatigue if you try to live up to that.
Right.
And I know you say, well, I don't do that for every patient.
Oh.
Does it really matter?
And whether you do it for one, they're special.
Right, right.
He reminds me of my grandpa.
Yeah, I have a close relationship with this family. I wouldn't do it for this person over here, but I'll do it for this one over here.
So in other words, you've taken those boundaries.
Mm-hmm.
You've got the fenced-in boundary for all your patients except for this one, and you just changed the fence, put the fence down so that they could do whatever they want.
Right.
No.
Right. No. It also creates an expectation that no one else on the team can help them like you do.
That can be really problematic. So
yes.
Mr. Smith calls on a Saturday at 5:00, and he says, hey, is Helen on call? I'm having trouble breathing. I need to talk to her. And the answering service says, well, Helen isn't on call right now, but Jerry is. I can put you in touch with him and have him call you. And Mr. Smith says, no, I'll wait till Helen comes back on.
Oh, that's not a good idea.
No, because first of all, Mr. Smith goes without treatment.
Right. for probably over 24 hours because Helen doesn't come back on until Monday, and it's now
Monday
Saturday.
Morning. Exactly.
So here's what we would say to families. Don't expect your nurse or social worker or chaplain to be available for you 24/7.
Or your aide.
Or your aide, for that matter. That's
Right.
true.
Right.
Now, your agency will provide a team member for your care, but it may not be the one that you're accustomed to.
Right. And yes, we all have our likes and our dislikes. We have people that we connect with very easily and some people not so much. But if they can provide the care that you need and they're competent, and it will get you through this particular issue or question or crisis until your assigned team member comes back, you're good to go. Go ahead and utilize that member of the team.
Right. Okay, so I told you that we communicate well and we talk a lot. So I think we've said a lot during this particular episode, and there's a lot to say about it, though.
You only pointed your finger a few times, and I think I rolled my eyes once, so that's pretty good, right?
I think it is pretty good.
And seriously, we have, between the two of us, we have 20 years of hospice experience. We have said these things. We have done these things. I have looked at a nurse who was going to be on call for the weekend and said, this patient that I have had for 2 years is imminently dying, is actively dying. Call me when she dies. I want to do the death call. And I can't see to this day, I can't tell you that that was a mistake, but that was not about that patient. I will tell you that. That was about me.
Sure.
That was about my attachment to that patient.
Right.
And so I would say that wasn't a particularly healthy professional boundary.
No.
Now, I did make myself available, etc. I can justify it all I want. See, I still can't let go of that. As a nurse, this is somebody I was very fond of, a very fine person that I connected with as her nurse. And I wanted to be there when she died. And I was. It was a very meaningful moment to me. But I think in some ways it also undermined the confidence that my team member that was on call had in herself. Mm-hmm. Because I was saying, this person is very important to me, but I don't trust you to take care of her death.
Yeah.
I should be the one to do that because I can do it better.
So we need to learn to kind of let go of those things and let the team handle them. I've had those times when I should have communicated something to someone and didn't. And then when it finally was communicated, they were very upset with me because I didn't say it in a timely manner.
Right. If I had known about this and this and this, nothing good ever comes from that.
Oh, yeah. No,
nothing
it never
good
does.
ever comes from that.
So what we're telling you through all of this is that we want you to not make the mistakes that we've made.
Yeah. Learn from the errors that we've made.
Absolutely. And so we want you to improve your communication, because truly communication is the lifeblood of what we do. This is how we do it, and how we can do it better is by communicating better. The better we communicate, the better our care is going to be for our patients and families. It's just bottom line. That's how it works. So we hope that this episode has helped you and given you some ideas of ways that you can improve your communication so that you can be better. Because it comes down to this one thing: improving the care for the patients. And if we can do that through better communication, we've done what we need to do.
Thanks for joining us today to listen to The Heart of Hospice. I'm Helen Bauer here with Jerry Finter. Because we know your hospice journey is 24/7, you can always find us at theheartofhospice.com. Subscribe to the podcast wherever you're listening and leave a rating or a review on Apple Podcasts.
To connect with us, just send us an email at host@theheartofhospice.com. You can also find us on social media. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.